So we are here this evening with Dr. Gold from Melbourne, Vieira, and Dr. Gold is the leading MS neurologist in this area. And my name is Stuart Schlossman of MS Views and News. And so we want to welcome Dr. Gold to this MS Clinicians Digest series. So thank you for joining us this evening.
Thanks for asking me to speak.
And what I'm here to speak with Dr. Gold about this evening is newly diagnosed MS patients. And what we would like to know firstly is what's your first interaction with with a newly diagnosed MS patient?
The interaction can be very complex. I think the initial interaction has to do with getting to meet and getting to know the patient. So I need to assess, how much they know about their illness, whether they've been briefed on it, whether they've been diagnosed previously, or whether they've just been, referred without a diagnosis. And I also need to learn a little bit more about the patient, what their fears are, what their risk tolerance is, and try to understand a little bit more about what they understand about the disease, how much reading they've done. So that first interaction is really a fact-finding for both of us. They need to learn more about their diagnosis, and I need to know more about them as a person. So I think that goes a long way towards understanding how much in depth I need to go with them in terms of talking about the diagnosis, talking about how to make the diagnosis, the symptoms to look for, and the treatment.
So when you now have this newly diagnosed patient and hopefully a caregiver there as well, is it just you educating them about MS, or do you refer them to any resources that they can pick up about the information as well, as far as websites, social media, how they can interact with other patients?
I think the first interaction, I'm usually talking to them about the diagnosis, how firm the diagnosis is, whether we have firmly established it or whether we need to do additional testing. I talk to them a little bit about the nature of the disease and how it can vary from person to person, and then how to go about approaching and diagnosing it and further treating it down the road. I often will ask them whether they've been doing any reading, try to refer them to reliable sources on the internet or in local support groups and self-help groups, and try to understand a little bit more about the disease before they jump full in terms of the treatment.
Great. So we've only been talking about, though, of what you're speaking about when you're first meeting with a newly diagnosed patient. How do you get to that point, though, of diagnosing a patient?
The diagnosis, in my mind, is complex and should be complex. There's a lot of detail that goes into it. We have to learn about the symptoms that they've had past and present. We have to know a little bit about the course, what kinds of testing has been done in the past, how that's changed over time, whether we can make the diagnosis immediately on a particular study like an MRI, or whether additional testing is needed to confirm the diagnosis.
So what kind of additional testing would you do to confirm the diagnosis?
In addition to MRI of the head, which is the most common MRI, we'll often look at the spine, the cervical and thoracic spine, or the upper and middle spine. We may do additional tests like evoked potentials, and we may do blood work to exclude other conditions, and we'll also at least consider a spinal tap if the diagnosis is not completely clear.
So MS replicates, or symptoms of MS are replicated in many different diseases. How do you get through the rule-out factor to come up with the words multiple sclerosis?
Part of it is trying to understand whether everything is fitting in to the MS picture in terms of their history of a relapsing course, whether they're showing some signs on their examination, whether they've had MRIs that show both past and present plaques or exacerbations or flare-ups. And then we try to then take that information and come to some sort of understanding. A lot of times there's enough question on the MRI or in the history that we do need to investigate other conditions. We need to look at their blood work for things like diabetes and thyroid disease, vitamin B12 deficiency, and some of the more unusual diseases like vasculitis, lupus, rheumatoid arthritis, and so forth, which may produce symptoms that can mimic MS.
Okay, thank you for that. But now, how do you explain to the patients about the white matter or the gray matter?
Okay, the white and the gray matter I think goes into helping them understand a little bit more about the anatomy. In other words, knowing what the brain is involved. It involves both the cortex or gray matter and then the white matter, which are the tracts that extend down to the rest of the brain and into the spinal cord. So at that point, there is that educational component, depending on how much they've read and understand, to explain what the white and the gray matter is involved. A lot of that's demonstrated by the MRIs. The MRI can show those kinds of abnormalities and can demonstrate to the patients where we make the diagnosis, how advanced the disease might be on the basis of the MRI, and then how we monitor over time how those gray and white matter changes occur.
Okay, so thank you for that answer, but now let's go to another step. Obviously, MS attacks people differently, and you see varying stages of MS when people come in even for the first time. When a person comes in and they're not really showing symptoms, how would you treat them with relapse MS versus somebody that comes in that is having severe walking difficulties or somebody else with severe cognitive issues?
When the person comes in with relatively few symptoms, it may be one symptom, one group of symptoms, or they may come in for a completely unrelated reason. They had a head injury and they underwent MRI to try to determine if there was any damage to the brain. And when they pick up abnormalities that suggest MS, then we can't just make the diagnosis without having some variation over time and at different parts of the nervous system that would point to multiple sclerosis. So oftentimes we'll repeat their MRI, we'll do the testing while we're waiting for those studies. We'll ask them to look for symptoms either in the past or in the future that may sound like MS. So sudden numbness or sudden visual disturbances, difficulty with bladder or bowel. And so if there's a question about the diagnosis initially based on symptoms, oftentimes we can look in different areas. We can look in the spine, we can maybe refer them to an optometrist or ophthalmologist, we may refer them to a urologist or urogynecologist to understand a little bit more about the bladder function. And so we may be able to sift out by that and put the pieces together to come up with a diagnosis. When someone's already coming in with advanced disease and they're already having cognitive impairment and motor impairment, balance problems, at that point the MRI becomes crucial in terms of how advanced it might be and how aggressive the treatment must be. So I often talk to patients about adapting the treatment to the severity of the disease. So if someone's having very inactive disease or very mild disease, we might choose one form or group of therapies. If someone's having very aggressive disease on their history exam and MRI, we might look towards more aggressive treatment. So we adapt and modify our treatments based on their presentation.
So that's about the patient primarily, though, with relapse MS. Now what if you're presented with a patient that's coming in basically for the first time, that you're diagnosing that patient with secondary progressive MS? What do you discuss with these patients?
Well, if they're in secondary progression, then presumably they already know well enough about the disease and what it's done to them. They understand the treatments that they've tried and now are failing. And then we have some careful discussions about being realistic about what treatments can do. We may want to look at other disease-modifying therapies, but understand that we don't have a specific treatment that's designed for preventing secondary progression. We may actually see some improvement or at least stabilization with changes in therapy, but we don't have anything that will change the ultimate course if they're already in a more advanced and progressive phase.
Well, thank you for that answer. So the next one is, you are now presented with a new patient who you just recently diagnosed with MS. That person was never diagnosed previously, and you find out in a few months from now that this person is just advancing way too rapidly. What and how do you go about your discussions with this person and their families?
The more advanced MS, the disease that's progressing rapidly, that they're accumulating symptoms, accumulating disability. In other words, they're not recovering fully from their attacks and often are left with some more permanent symptoms. And oftentimes there's a correlation with the MRI that's showing more aggressive disease. So those are the patients that we have a whole another discussion, and that is untreated, then we can see that these patients are more aggressive, and if they're not being treated aggressively, that they may very well lead to pretty severe disability within a short period of time, a year, 2 years down the road. And those are the patients that we have to weigh those risks and benefits. We have to say, okay, we know that the risk of going on to developing severe disability is hitting you in the face, and it's almost 100% at this point that you're going to get worse. How do we deal with that and weigh that against the risk of some of these more aggressive therapies? So therapies that might involve risk, things that might involve risk of infection, such as PML. They might have side effects that we have to be concerned about. But I think people need to think differently about their disease in order to gain benefit from those more aggressive treatments. And that's where you have to carefully balance out those risks and benefits.
Do you find that any of the newly diagnosed patients are being quite proactive with their own illness? And do they come to you suggesting things that they would like to try, and that you agree with them or disagree with them? Do you find this just more common these days than in the past?
I think certainly with the media and with the internet, people are reading more about their disease and sometimes reading about things that are not really approved by the FDA or accepted in the neurology circles and neurology treatment areas, such as in the universities. So I think once people come in with those kinds of directives and treatments that they would like to try, I think we have to balance those out with some of the standard treatments as well as some of the things that they are looking at. So sometimes we can combine therapies. We can combine what they want to use along with the traditional therapies, but then we may say, okay, well, your treatment is much more aggressive than we can handle here. We'll send you to a university where they may be able to provide that kind of treatment, such as stem cells, and let them see if they might be a candidate. A lot of times, unfortunately, we try to discourage those things from people who haven't really tried standard therapies, because they may very well do great with them, and they can save themselves some of the side effects and risks that's involved with some of the other types of therapies.
Aside from the DMDs or the DMTs, as we also hear them called, what complementary or alternative therapies that complement the actual DMT medications do you recommend for patients?
Nowadays, I think we're becoming much more holistic about our approaches. So a lot of that is driven by the patient who wants to look at other things besides just medication. Sometimes they even want to look at things instead of medication, which we often will discourage. But some of those other things are looking at the basics: regular exercise, proper sleep, proper nutrition, looking at ways to maybe supplement with certain vitamins, such as vitamin D, biotin, things of that sort that can actually provide some benefit and actually has some scientific grounds to support those benefits.
So a lot of people have been asking me about biotin. Can you, we're differentiating a moment away from what we were speaking about, because I just want people to hear more about biotin, if you don't mind.
Early last year, there were a couple studies done using biotin in a blinded fashion against placebo in patients who had progressive forms of MS. And they were using doses between 100 and 300 milligrams per day, which, if you look at some of the over-counter uses, such as for hair and nail growth, it's only 10 milligrams a day. So the doses are much higher. And so what we've done is found that they do show some benefit in several of the studies. We're encouraging patients to go on to the medication or consider starting it's actually a vitamin B7, but encouraging them to take a look at that, because I think there is some benefit. Some people are seeing improvements in their fatigue levels, in their walking, in their vision, and so forth. So I think there is some potential benefit. We don't know all the ways it works. It seems to be working through mitochondrial energy stores and so forth. So I think it looks like a promising type of supplement that doesn't have a lot in the way of side effects. I haven't heard about any people talking about severe side effects. I've had a couple of people tell me that they had some swelling of the lips, but that may be as much the formulation. But for the most part, people have tolerated it well.
Yes, to be fair and balanced, I was going to ask if there's any negatives to using biotin. So.
Of course.
Okay. So going forward again, when you find somebody newly diagnosed and they are suffering one relapse, or they just had a relapse and that's why they came in and you tested them and found out that they are positive for multiple sclerosis, and you find that this person might be relapsing again shortly after you just put them onto a medication, what is your next step?
Usually if it's shortly, when you say shortly, it's within the first 3 to 6 months of therapy, then sometimes we can still treat those patients as you would any other relapse with steroids and so forth. I think one of the drawbacks of a lot of the medications is that there may be a lag time between starting the drug and then seeing the full benefit. So we don't give up on a drug for at least 6 to 9 months in my mind before we start to think about a failure of that drug. But oftentimes we can combine the disease modifier along with the acute therapies and treat both, treat the prevention as well as the acute relapse.
Thank you. And if a person comes in and you see them with mobility issues, what do you recommend for this person?
Mobility issues meaning?
Walking difficulties.
Primarily walking. So under those circumstances, whether it's early or advanced, I'm usually trying to get the physical therapist involved if they're not already involved. And I try to encourage patients to look at that physical therapy as a way of jump-starting them into getting into an exercise program, trying to improve the mobility with the basics and not relying just on medication to try to gain some mobility.
Speaking about exercise, how do you inform a patient that might have heard that exercise might be bad for them? How do you refer and tell them that it's actually good for them?
I think it's just a matter of education. Any kind of activity can be bad if you're doing it the wrong way or if you're excessively trying to work out. But I think a lot of it is educating the patients, helping them to understand the kinds of techniques that are available through physical therapy, going to a reliable gym where they do have a trainer or a physical therapist that can oversee their care. So much of it is education, and then hooking them up with people that are knowledgeable about MS and other disabilities and helping them to get through it. They've even developed programs with yoga and other things to help patients to get through with disabilities to try those techniques out as well.
Great. And so now, again, what would you say to a newly diagnosed patient now versus how it might have been 10 years ago, as far as when they come in, they're diagnosed, and again, you're consoling them, you're helping them to better understand multiple sclerosis. How do you educate them on the benefits of being diagnosed now versus what could have been for them back then?
Certainly, and I even go back 20 and 30 years before we even had treatments. I can compare to pre-treatment options. I think much is geared towards understanding their viewpoint, how much they understand, what their fears are, and then helping to understand that the prognosis for patients nowadays is vastly different than it was 20, 30 years ago when we didn't have the disease modifiers. I think certainly they need to understand that early treatment compliance is important. Try to keep up with their physicians and monitor the disease closely. So if they start a particular therapy and it's not working for the disease, or if they're not tolerating it adequately, we can make switches now that we couldn't make back then. 20 years ago we had 1 or 2 drugs. Now we have over a dozen drugs to choose from. And so patients have choices. They can move on to things that are more effective for them as an individual rather than just throwing everyone on the same drug that was available at the time.
Well, thank you. I think that this was great, Dr. Gold. I thank you for coming and speaking with us today.
Thanks again.
It was a pleasure.
Thank you.
Thank you.